This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending neurosurgeon.
And I'm Dr. Ilara, a research fellow. Today we're looking at a fascinating new study from the journal Neurosurgical Review, published in 2026. It's a systematic review by Levin-Karian and colleagues titled Bilateral Decompressive Craniectomy in Pediatric Patients.
This is a topic that hits close to home for anyone who covers pediatric trauma. We've all been there, a child with a severe traumatic brain injury or a massive non-traumatic insult. And despite our best medical efforts, the intracranial pressure just won't stay down. We talk about decompressive craniectomy, or DC, as a salvage intervention. But when we move from unilateral to bilateral procedures, the data gets a bit murky, especially in the pediatric population.
Exactly, Dr. Aris. The authors point out right in the introduction that while pediatric patients often have a high recovery potential, they are also particularly vulnerable to acute intracranial hypertension. Unlike our older adult patients, children often lack the degree of cerebral atrophy that provides that crucial compensatory intracranial reserve. When their brains swell, there's simply nowhere for that pressure to go.
Right. The Monroe-Kelly doctrine is much less forgiving in a young, full brain. And while we have randomized trials in adults like DECRA or Rescue ICP, the authors emphasize that we can't just directly extrapolate that data to children. Pediatric patients differ significantly in injury mechanisms, skull and brain development, and cerebral compliance. So, Ilara, how did this systematic review approach the problem?
They followed PRISMA guidelines and searched across PubMed, Scopus, Embase, and PubMed Central. They were looking for English language studies reporting on 4 specific techniques: bifrontal, bitemporal, bilateral, or cruciate decompressive craniectomy. They defined pediatric or young adult as anyone aged 21 or younger who had refractory intracranial hypertension.
That's a fairly broad search, but I imagine the actual number of high-quality studies was limited.
It was. After their screening process, only 5 studies met the eligibility criteria for the primary pediatric and young adult emphasis. This included 1 small randomized pilot trial and 4 observational cohorts. The overall evidence was described as sparse and heterogeneous.
Only 5? That really highlights the neurosurgical desert we find ourselves in regarding standardized pediatric trauma protocols. Before we dive into the outcomes, let's talk about the operative taxonomy they used. They mentioned several different bilateral approaches.
Yes, they categorized them as bitemporal, bifrontal, bilateral, and the cruciate approach. These strategies were used primarily in selected patients with either severe TBI or diffuse cerebral swelling. Interestingly, they found that even in larger pediatric DC cohorts, the bilateral or bifrontal subgroups were often quite small, and the outcomes weren't always stratified by the specific technique used.
That's a major hurdle for us in the OR. If I'm deciding between a massive bifrontal versus a bilateral hemicraniectomy, I want to know if one offers a physiological advantage over the other. What did the review say about the ICP response and functional outcomes?
In the limited reports they found, early decompression was associated with a reduction in ICP, and in some cases, favorable outcomes. For instance, that 1 small randomized trial showed some promise. However, the authors were very clear. The evidence remains insufficient to determine comparative efficacy or to say that one bilateral approach is superior to another.
Let's talk about the cruciate approach for a second. It's a term we don't hear as often as the standard bifrontal. For the residents listening, this involves a cross-shaped dural opening, often combined with extensive bone removal. The fact that the paper included this in their search shows they were looking for any salvage strategy that addresses bihemispheric swelling.
And the indications weren't just limited to trauma. While TBI was the most frequent, they also looked at non-traumatic etiologies causing refractory ICP. But even then, because the studies were so varied in their ICP thresholds and the timing of surgery, it's hard to draw a hard line on when to pull the trigger on a bilateral procedure.
What about complications? Decompressive craniectomy isn't a free lunch, especially in kids.
Absolutely. The review noted a variety of complications across the studies. We're talking about hydrocephalus, subgaleal collections, and the need for reoperation. They also noted that reported mortality and functional recovery varied significantly. One of the biggest issues they highlighted was the lack of standardized complication reporting and long-term neurocognitive outcomes.
That long-term piece is vital. In pediatrics, survival isn't the only metric. We care about school performance, social integration, and developmental milestones. If the review couldn't find standardized data on that, it makes our counseling with families very difficult.
Exactly. The authors mention that current evidence is not only sparse, but often not technique-specific. We're often looking at pooled data, where a few bilateral cases are tucked into a larger study of unilateral decompressions. This prevents us from seeing the unique complication profile of, say, a bifrontal versus a bitemporal approach in a child.
So if I'm a resident on a Friday night with a pediatric TBI case and diffuse edema on the CT, what is my takeaway from this 2026 review?
The takeaway is that bilateral, bifrontal, bitemporal, and cruciate DCs are feasible salvage strategies for carefully selected patients. If medical therapy has failed, these are options on the table. However, you can't look to the literature yet for a gold standard on timing or specific technique. The authors state that definitive conclusions regarding efficacy or superiority just cannot be made with the current data.
It's a call to action, really. They conclude by saying we need prospective multi-center studies, and they were very specific about what those studies need: standardized age definitions, clear ICP thresholds, a unified operative taxonomy, and most importantly, those long-term neurocognitive outcomes.
They even suggested that the lack of compensatory reserve in children makes these studies even more urgent. We need to know if we are truly improving the quality of life or simply shifting the mortality curve.
It's a sobering reminder of the limits of our current knowledge. We use these procedures as a last resort, but we're still operating in a space where the best way to do it is still being defined.
It also points to the methodological heterogeneity of the studies we do have. When every surgeon is using a slightly different technique and a different threshold for what refractory ICP means, it's nearly impossible to synthesize that into a single guideline.
Well, Ilara, I think this paper is a great baseline for our residents to understand the state of the art, or perhaps the state of the uncertainty, in pediatric bilateral decompression. It's a feasible salvage, but it requires careful patient selection and a high degree of clinical judgment.
I agree. It's a reminder that in the absence of Class 1 evidence, we have to rely on the physiological principles we know, like the vulnerability of the pediatric brain, while we wait for more robust multi-center data.
Well put. That's all the time we have for today's deep dive. Thank you, Dr. Ilara, for walking us through this systematic review.
My pleasure. We hope this helps our listeners when they're faced with these challenging cases in the PCIU or the OR.
Until next time, keep learning and keep operating. This is the Neurosurgery Hub podcast.